We'll talk about RCG Green Term Guideline, the identifications and management of maternal sepsis during and the following pregnancy. Okay. What are the key recommendations? Consider sepsis as possible diagnosis in all women during pregnancy and in the intrapartums and postpartum period with suspected infections and whose clinical conditions rapidly deteriorates. Very very important. If sepsis is suspected in the community, urgent escalations and referral to hospital is indicated. Monitoring of a woman with suspected sepsis should be performed using early warning systems, that early warning system modified for obstetrics, managed through a multidisciplinary approach with early escalations and senior inputs. Serum lactate should be measured urgently in women with features indicating high risk of sepsis. Serum lactate, if more than 4 millimole per liters or more, should prompt immediate escalations of care, including consideration of discussion with critical care teams. Any relevant imaging studies should be performed promptly to confirm the source of infection has to be identified. Use of sepsis bundle may improve compliance with urgent management in women high risk of sepsis. Administrations of intravenous broad spectrum antibiotic is recommended within 1 hour in women at high risk of sepsis or with or without septic shock. In critically ill pregnant women, the birth of the baby can be expedited if it would be beneficial to the woman or the baby to both. A decision on the timing of and the mode of birth should be made by senior obstetrician following discussion with the woman and the family if her condition is permit. During the interpartum period, continuous electron fetal monitoring is recommended. Cautions is required if considered fetal blood sampling. An individual risk assessment should be made by senior anesthetist with regard to type of anesthesia. Investment babies when treated as sepsis during labor in the 24-hour period before or after birth require assessment respected clinical indication renal infection. If either of the woman or the baby is infected with invasive group A beta hemolytic streptococcus, then in postpartum period both should be treated with antibiotic and fluid infections control precaution adapted, including barrier nursing pre-rectal gradient. Herpes simplex sepsis is rare but potentially fatal disease. If contracted in peripartum period, more need to be done. Raise awareness as it is a potential diagnosis to exclude sepsis pathway and for early consider use of acyclovir. Which women are at risk of sepsis? All women at risk of sepsis during pregnancy and the postpartum period. During pregnancy, and the postpartum period, clinicians should be aware of and able to recognize the risk of developing factorial sepsis. Women at risk of sepsis in pregnancy should be made aware of this, provided information including access to care, reduced risk. The risk factor for developing maternal sepsis during pregnancy or during postpartum period is maternal risk factor, like if it is obesity, diabetes in pregnancy, iron deficiency, anemia, maternal age more than 35 years, impaired immunity or immunosuppressions in medication using, women, ethnic minority, renal or cardiac liver diseases, history of pelvic infections, contact with the group A beta hemolytic streptococcus, intravenous drug use, obstetric if a prolonged rupture of membrane, cesarean sections, vaginal trauma, written breast and pregnancy tissue, amniocentesis, other invasive procedure, multiple gestation, cervical circles. What are the likely causes of sepsis outside of the genital tract and how might we they identify? A thorough history is recommended as soon as possible after presentations. An appropriate physical examination has to be done. Consider investigate other non-infective causes that cause masquerade the sepsis. Recognize what should prompt recognitions. Consider sepsis is a possible diagnosis in all women during pregnancy in postpartum period with suspected infections whose clinical condition rapidly deteriorates. The potential site of sepsis outside the genital tract, clinical feature of the presentations. If you suspect it is from the site is head, then meningitis, meningoencephalitis. The clinical feature like photophobia, neck stiffness, altered conscious level, deliriums, focal neurology, seizures, ear ENT, suspected otitis media, sinusitis, pharyngitis, laryngitis. The symptoms are earache, muffled hearing, purulent nasal discharge, facial pain, headache, sore throats, cervical lymphadenopathy, hoarse voice. Then from chest, you have to rule out pneumonia, viral bacterial pneumonia, cough with sputum is more likely bacterial, hypoxia and pleuritic pain is there. Cardiac causes, infective carditis, regurgitant murmur will be there, and embolic lesions like sphincter hemorrhage, January's lesion has to be there. Hepatobiliary pathology, there cholecystitis, cholangitis, That the right upper quadrant pain, Morpheus signs positive for cholecystitis, upper abdominal pain relating to back. In abdomen, there is a pancreatitis, gastroenteritis, appendicitis, diarrhea, vomiting, smack bone signs for appendicitis, atypical presentations common in pregnancy, acute abdomen, bowel formation more common in inflammatory bowel diseases. In breast, mastitis may lead to breast abscess, necrotizing fasciitis, toxic shock syndrome, the inflamed breast pain, features of sepsis, bruising, deeper infections such as necrotizing fasciitis. Very, very important. The locus has to be ruled out in all patients. Okay. In urinary tracts, urinary tract infections, pyelonephritis, goblet, genital herpes, dysuria, low brain back, hematuria, acute urinary incidence. Regional anesthetic, blockage related infections, meningitis, septal abscess, headache, photophobia, back pain, focal neurology, wound infection, peripheral cannular thrombophlebotomy, seizure and bath, epistemic necrotizing fasciitis, early necrotizing fasciitis, non-infective causes that can masquerade the sepsis like blood transfusion reactions, autoimmune disease, acute fatty liver pregnancy, they have a fever history, disseminated malignancy, thrombotic thrombocytopenic purpura, pyrexia, acute renal failure, altered consciousness, thrombocytopenia, hemophagocytic thrombocytosis, pyrexia, pancytopenic lymphadenopathy, occult bleeding, hypothermia, raised lactate shock, epidural related mental fever, pyrexia, mesoprostral side effect, pyrexia. The clinical symptoms and risk factors suggest sepsis during pregnancy. Objective evidence: alter mental status, GCS less than 15, not a lot. In ABPA classification, respirate more than 25 breaths per minute. Oxygen saturations less than 94% on room air. Heart rate more than 130 beats per minute. Blood pressures more systolic is less than 90. Urine output not past urine more than 12 hours. If catheter is less than 0.5 ml per kg per hours. There is a red flag sign. These are the red flag signs suspected sepsis that indicate high risk of sepsis. You have to recommended immediate management either with can initiate sepsis bundle care for patients in patients or referral by blue light transfer from the community. Then amber flags or features in patients with suspected sepsis that indicate moderate risk of sepsis. This warrants senior clinical review within 1 hour for inpatient as soon as possible in the community. Behavioral mental status changes, acute deterioration in the functional ability, respiratory rate 21 to 24. Heart rate is 100 to 130 beats per minute or new dysarrhythmia. Systolic BP is 90 to 100 mmHg. Urine output NAS pass in urine last 12 hours. If catheterizations 0.5 to 1 ml per kg per urine hours. Has had an invasive procedure in last 6 weeks. Cesarean birth, assisted vaginal birth, surgical management of miscarriage, circles, CVS, amniocentesis, miscarriage terminations, impair immune systems, illness, medications, including oral steroids, temperatures, current diabetes or gestational diabetes, temperature less than 30 or more than 38-degree, close contact with the group is group. Scarlet fever tonsillitis, prolonged close contact with this household setting, prolonged rupture of membrane, prolonged vaginal bleeding, abdominal pain, offensive vaginal distress, altered vocal pain, unresponsive. What is the optimum way to monitor women with suspected sepsis should be performed using an early warning system, modify obstetrics, manage through a multidisciplinary approach. What appropriate trigger features sepsis that prompt hospital admission? If sepsis is suspected in the community, urgent escalation refer to the done. Common investigation blood culture is a key investigation. Two sets should be obtained prior to antibiotic administrations. However, antibiotic treatment should be started without waiting for microbiology result. Consider HSV polymerase reaction when indicated. Serum lactate should be measured urgently in women with feature making them a high risk of sepsis. Serum lactate 4 millimole per liters or more should be prompt immediate escalations. Consider the critical care teams. Recommend any relevant imaging study that has to be performed promptly to confirm the source of infections. This may include pelvic ultrasound scan, computer tomography scans, if pelvic abscess is suspected, or chest X-ray if possible chest pathology. Other microbiology samples should be guided by the clinical suspicious focus of infection appropriates. Routine blood tests should be including pool blood count, coagulation screening, urea, electrolyte, creatinine, liver function tests, CRP, venous blood gas, other near glucose, lactase, appropriate virological testing like SARS COVID-19 test already indicated. Any human who is unwell with symptoms should have a throat swab sent for bacterial culture. MRSA status women unknown pre-moistened noise pre-moistened nose swab should be sent for rapid MRSA screening where such test is available. Prior note history regarding infection suggestive cause of sepsis. Dysuria, flank pain, urinary tract infections, acute urinary retention, IV drug use, recurrent skin, severe respiratory infection, gastroenteritis, zoonotic infections, allergy, malaria, asthma. What is the approved of the influenza specialist? Early fluid resuscitation crystal should be administered with an immediate 500 fluid bolus in women with hypertension or elevated lactate above 4 ml. This may need to repeating when indicated. Urine output should be measured with precision using hourly monitor. Urometer choice of empirical antibiotic therapy should be guided by local epidemiology, reflecting the incidence of resistant organism within that geographical area. Information about antibiotic therapy, limitation, antimicrobial spectrum given in table. For life-threatening sepsis, where the sensitivity to the organism or unknown combination either piperacillin tazobactam or merophenoms gram negative covers plus clindamycin for gram positive and anaerobic organism provided very broad above cover, but local guidelines should be consulted discussed with any University of MRSA. The addition of vancomycin is advisable. Empirical antimicrobials should be reviewed with conscious result targets agent as soon as clinical. If change in antibiotic regimen is considered because deterioration despite first line treatment, consider the addition of IV acyclovir 508W as part of the second line treatment. Regular senior clinical review has to be done. And IV broad spectrum antibiotic recommended within 1 hour women with high risk sepsis. ICU transfer indications to transfer intensive care unit cardiovascular hypertension less than 90 systolic and raised serum lactate more than 4 millimole per liter persisting despite fluid resuscitations. It was suggesting the need for vasopressor inotrope support. Okay, when you transfer the patient to the ICU, if a cardiovascular causes like hypertension, less than 90 systolic or raised serum lactate more than 4 millimole per liter, persisting despite fluid resuscitation, such as the need of vasopressor or inotrope supports. Respiratory, there will be a pulmonary edema, need for mechanical ventilations, need for airway protections. Renal replacement therapy, neurological decrease conscious level, miscellaneous multi-organ failure, uncorrected acidosis, hypothermia. These are the indications to transfer issue. Antimicrobial choice limiting antimicrobial spectrums. Co-amoxiclav no active against MRSA, Pseudomonas active against most streptococci, staphylococci, and are many gram negative. Metronidazole only cover anaerobes. Clindamycins, UK should no longer use GVS prophylaxis. Pictas, but also many gram positive, gram negative organisms, including Pseudomonas. Renal sparing in contrast to aminoglycoside. Poor activity against ASBL producing coliform. Cephalosporin subtraction no active against ASBL producing coliform. Pseudomonas, MRSA. Beta hemorrhage streptococci. Carbapenem very broad spectrum. Most gram negative, including ASBL producing anaerobes. Gentamicin mainly gram negative cover, including Pseudomonas. Vancomycin cover MRSA. IV immunoglobulin should be considered as part of treatment of gram-positive necrotizing infections, toxic shock syndrome. When other measures failing, this should be limited. Sickest women administered critical care setting with a blood warming device. The main contraindication of IV use is congenital immunoglobulin deficiency to the mothers. How should the fetus monitor and time mode of birth in critically ill pregnant women's birth of the baby to be expedited if it would be beneficial to the women's of the baby? A decision as the time of mode has to be decided with the discussion of family. Magnesium sulfate should be considered if indicated. Consideration should be given to antenatal corticosteroid for long maturity during the intermittent continuous if electrophytal monitoring has to be done. Medicine era obstetrician anesthesis. Babies treated for sepsis during labor or in the 25 period of before after the or you can as a risk factor clinical indication of neonatal infections. If either woman or baby is infected with disease in the postpartum, both should be treated with antibiotic. Group A streptococcus. For the postnatal care infection control issues, all pregnant women who have recently given birth should be informed the signs, symptoms, and genital infection. Any group where is not different during pregnancy should be treated aggressively. Full infection control precautions. Can sepsis be prevented? All pregnant women and women who have recently given birth should be informed the signs and symptoms of sepsis. Healthcare.